Thank you very much, Sue. Can we have the first slide? Brilliant. So, hello, everybody. It's absolutely fantastic to have this opportunity once again to talk about my favourite subject, continuity of carer. I just want to set the scene for you all today in thinking about how continuity of carer really does make a difference to health inequalities. And with me this evening, I've got the very wonderful Charlotte Clayton, who has really been looking at a micro level at what impacts the lives of families and also of midwives who've been doing continuity of care for a long time. We have to remember the context in which we're working. Our current services are broken, going all the way back to Northwick Park in 2005 to modern day. We've had report after report that has told us the same things. There is nothing new. Culture, leadership, staffing, risk assessment have been lacking, but that is because of the way we do our current way we do our service delivery. We've also got research from places like the Whelm study that say delivering care in the way we do makes midwives very unhappy, and therefore we have to agree that we have a very strong case for change. We know we need to change. We've got the evidence for why things aren't working, and we know how we need to change. We've got a solution, and we just need to think about ways of how we can reach that new place of service delivery that's going to make things better for everybody. The answer is we've got to start thinking about things in a different way. So Albert Einstein said, if we keep doing the same thing over and over again and expecting different results, well, that's insanity. And that's what we've been doing in maternity services for at least as long as I've been in senior leadership, over the last 15 or so years. And we've also got Kirkup, who said very clearly in the East Kent report, if we don't begin to tackle this differently, there'll be more. And he's actually been doing reviews, as he says in his opener, since 1967. So it tells us that our current service delivery models simply don't work, and we have to do something different. Now, when thinking about transformation, we've got to think, if I was a caterpillar, I would have no notion of what being a butterfly would look like. And that's partly what we have to think about as we think about transformation within the context of maternity services. In undergoing that change, we have to be ready to think about the problem and think about the solutions in a completely different way, as different as a caterpillar is to a butterfly. Next slide, please. So we do have a way out. We need to agree our vision, and we need to understand and use the evidence we've got. And actually, it's not just our 3 Cochrane reviews that we've got around specifically midwifery continuity of carer, but we've also got other evidence, for example, from primary care, where GPs provide continuity, people live longer. We've got global health examples that tell us where you have a relational intervention, health outcomes significantly change. So we have some really key data sources. And I'd like to point you to Hannah Raymond-Jones, who was actually at my at the research conference this morning, and she's done a lot of work that says continuity of care makes a significant difference to vulnerable women and women living in deprivation, and indeed women who are Black or Asian or mixed race. You've also got work from Anthony Costello that did a huge piece of work across the Indian subcontinent, which was a relational intervention, and it reduced perinatal mortality by 1/3, which I think is absolutely incredible over humongous amounts of people. And he found that standard healthcare didn't make a difference. He tried to get people to wash their hands, and they just didn't listen to them. But when he tried a relational intervention, suddenly everything changed, and babies stopped dying, and clinical outcomes improved. The other thing we've got is work by someone called Joseph Kai, 2007. He looked at healthcare workers, and what he said was, people don't intend to care for people who are different to themselves in a negative way, or they don't intend to be rude, or they don't necessarily intend to do anything bad. But the reality is, because they're anxious about dealing with someone who's different to them, they get anxious, and therefore they make mistakes and they make assumptions about people. And as we're thinking about personalised and culturally sensitive care, we have to be brave, and we have to start building that relationship, which gives us the positioning to be able to ask people about what they prefer and what they need, and is it all right to touch you, and so on and so forth. So we're absolutely confident and sure, as well as having 3 Cochrane reviews with a 4th one on its way, that giving care in this way absolutely saves lives and
improves outcomes for people. In addition to all of this, of course, we've got a mandate from the select committee within Parliament that reviewed all the things that we were trying to do, and hit that the only criticism we got really was we need to be doing this quicker. So continuity of care is the appropriate thing to do to bring about the changes that we're seeking, but we're just not doing it quickly enough. So what do women want? We interrogated the CQC results of 2019, and what we can say is where women had continuity of care, and it wasn't loads of people, but there was a significant amount. What they reported was in 38 out of 42 items, care was reported as being significantly better. And when you can interrogate the detail of the slide yourselves if you want to. So the vision that we're trying to communicate is that our default position is that all women are cared for within a continuity team model. That means I pick you up at booking, and I and you together organise ourselves in such a way that I'm able to provide all the antenatal care, and either me or my team will be available for your birth, and then I will give you your postnatal care. And so it really is a relational thing. It also gives us the opportunity to build communities and do creative caring, because I've only got a caseload of 27 live, or a live caseload of 27, and therefore we can do many things that we'd never have dreamt of being able to do within the standard programme of care. Each midwife has 36 completed cases a year, and the midwife team is about 8, so they really can get to know each other. And what we want to do in this context, and we've already got that in place, is that we're rolling out the teams in areas of greatest need first. Every team member should have, should have an obstetrician, and there should be a strong team ethos that allows for fresh eyes, a microcosm of clinical governance that feeds up to the wider board. So that your chief nurse in your service will know that you over there in that little service over there and that little team over there are giving top quality top quality care. But ultimately, the whole maternity service delivers continuity of care. So at this point, I'm going to hand over to Charlotte, who has been looking at a microcosm of care.
Hello, thank you so much for that kind introduction, Trixie. So I am going to talk to you a bit about my PhD research. But just before that, I wanted to take a moment to thank my PhD sponsors. The Ilanthi Midwifery Trust awarded me last year the Midwifery Research Fellowship, and this is supporting me in the last parts of my PhD with the writing and dissemination of my PhD. And my original funders, Bournemouth University and the University Hospital Southampton. Without the support of these organisations over the last 5 years, this research would not be possible. And my research is a grounded theory which has examined the public health role of caseloading midwives working in areas of high deprivation. And tonight I'm going to share some of my research findings with you all. My research was co-created with stakeholders at Bournemouth University and maternity service users and staff at the Princess Anne Hospital in Southampton. Southampton have over 20 years experience of providing midwifery continuity of care to women and their families in the most deprived areas in the city. And they've contributed to population health in many nuanced ways which have not previously been explored. Working in 3 teams of up to 8 midwives, supported by link consultants and midwifery support workers, the teams provide care across all 3 phases of the maternity care pathway. And they've experienced waves of policy development, transformation and innovation over the years. My research was developed out of a local priority to understand the nuances of the public health role of caseloading midwives, working in the 3 teams across the city through the perspectives of the women and midwives themselves. My study employed the use of a methodology called constructivist grounded theory to examine the phenomenon, and this methodology is well suited for social science research that seeks to uncover the underlying mechanisms of a social process, such as relational-based continuity of care and its outcomes. The study itself was set in the context of the COVID-19 pandemic, and I had the honour of being able to listen to the experiences of 36 participants during the second and third national lockdowns in England. So some of the main findings I wanted to share with you tonight. The first ones that we'll look at here are some quotes from women that I had the pleasure of interviewing. I wanted to share with you how the women felt about their midwives and how they contributed to their health and well-being from their perspectives. Interestingly, you'll notice from the word cloud here and also on the pages related to the midwives findings, midwives and women actually shared a similar language in how they described their experiences and their perceptions about the public health role and impact of caseloading midwives. I just want us to focus on the top right-hand story here. We'll call this participant Michelle. Michelle was an incredible woman. Prior to her contact with her caseloading midwife, social services were working closely with Michelle and her family because her partner, her children's father, was suffering with a drug and alcohol addiction, which had caused considerable dysfunction within their family unit. Michelle's partner was mistrusting of social services and had previously declined addiction support, which was threatening the possibility of further social service intervention. After working closely with Michelle's midwife, he agreed to being referred to a specialist addiction service. This opened up a wealth of support for him and their family, as you can see from Michelle's quotation here. But I just wanted to provide a little bit more context. Michelle said, "My support worker couldn't believe the difference from meeting us to the difference from when she was signing us off. And it's all thanks to Racer that we finally got the support that we needed to finally give us a better lifestyle than we had." I'll just give you a few moments to just muse over some of the quotations, but on this slide, I wanted to focus on the quotation from another participant, and we'll call her Poppy. Due to the motivational interviewing and trauma-focused mental health support that she received from her midwife in collaboration with her community mental health team, Poppy felt ready to process the complexities that she had experienced in her childhood. Prior to her contact with her caseloading midwife, she felt unable to face them directly. And she says here, "I finally feel like I'm able to deal with my childhood and go through stuff and ask questions I've always wanted to ask." So we'll now look at some of the findings from interviews with midwives. Two of the most meaningful concepts in my research explored the impact of the work midwives did with women who were at risk of having their babies removed from their care, and also the community groups that midwives set up with children's centre staff to meet the needs of women who'd recently migrated to the UK. As the quote at the bottom of this page discusses, one of the midwives said, "We created an Afghan women's group and we helped them with English language lessons, contraception, infant feeding, vaccinations. It was all public health stuff. And eventually they had better English to sort of influence the other women in their communities." So what does all this information mean for midwifery continuity of care and our profession? Constant comparative data analysis, which are the tenets of constructivist grounded theory analysis, they revealed that we need to be harnessing the power of data to be able to evidence our impact on population health and strengthen our call for midwifery to be seen as a legitimate public health intervention that has longevity and does influence the health of women and their children across the life course. Caseloading midwives who took part in my research described a whole host of clinical and non-clinical skills and interventions that they employed in creative ways to meet the needs of their local communities that were not necessarily captured by clinical coding systems and fed therefore upstream regionally and nationally for reporting instances. For instance, midwives spoke about food, fuel, and housing poverty, This was collected in unstructured ways, if at all, and even after the implementation of a sophisticated maternity information system, issues like food and fuel poverty were not collected or reported on. Yet we know their impact on maternal and infant health and how these determinants continue to widen the gap in health inequalities between the richest and poorest in society. Midwives also spoke about their longevity of their love for continuity and that impetus to impact population health. Continuity of care is the answer to our problems in maternity services. And if we listen and learn from the experiences of those providing care, we will and benefiting from this model, the answers to our problems will be revealed on both a micro and macro level for population health. Thank you very much.
So I was just going to wrap up the session by saying that all of us, Wendy, me, and I'm going to be roping Charlotte in, as you can imagine, are all very keen to help services succeed with continuity of care, because as you can see, we've got such a strong case for and such a moral imperative for doing it. But in order to do it, we have to get strong foundations. We are about to launch the midwifery deployment staffing tool that will help people look at their staffing and become confident in their staffing, and the other building blocks are in the guidance. Next slide, please. People have asked, is continuity still a thing? And the answer is absolutely yes. It remains a national ambition. All we've said is we've taken away the target because of the significant staffing issues that services across the country are experiencing. But evidence-based care is gold standard. We have showed you from the evidence that I've mentioned, from what Charlotte's mentioned, and I'm sure Wendy will say even more about it in a minute. It is gold standard. We've got a moral imperative to do this. We are available to support you and help you. And what we're focusing a lot on, and you'll hear a lot about, is data, training, enhanced continuity. We've got 59 teams in play that we're funding at the moment, and we're hoping to double that over the next year. And we've also got 6 evaluations underway. As you know, there are many asks within continuity, within the maternity transformation program. But if you get continuity, and think of continuity as your vehicle, so you're going to change your service delivery model and you're going to use continuity as your vehicle, you'll be able to deliver all the other asks that you're asked to do, such as increasing breastfeeding, which is what Mary Renfrew said this morning, reduce smoking. Mary Renfrew also said that, to improve clinical outcomes. And final slide from me, please, is we have to remember that the pregnancy gives us this window of opportunity. It gives us a window to improve physical well-being, and so we change people's long-term outcomes, as Charlotte has been talking about and investigating. So that person, when they're healthy within the womb with their mother, doesn't drop dead when they're 60 years old because of what we have done as midwives. Likewise, we improve mental well-being, and where women are less depressed because of the care they've received during their pregnancy, they then read to their children, and their children are then ready to learn when they go to school. And then we will see a change in long-term psychosocial outcomes as well for these people. And on that note, I want to hand over to Wendy.